Yes. Kim did a great job assembling a wonderful panel for you, with the exception of the one going on right now, but it's all going to be okay. All right. So how many people think they've had some struggles with things going on through the pandemic, right? The good news is that we've been able to achieve more in terms of demonstrating value for EMS in the last 20 months than many of us thought we could do in the next 20 years. So if there's any bright side to what we've all had to endure over the course of the last 20 months and now, progressing, then this is it. So here's what we're going to try and do over the course of the next, now Kim told me I've got 12 minutes. So I'm going to speak very quickly, but you're going to get a handout electronically that actually has a lot more content to it. But we're basically going to talk about what are some of those opportunities that have been created because of the challenges of the storm of the pandemic. And we are going to ask some tough questions. Again, just to try and keep it relatively light. So let's talk about some of the questions that we're going to ask. Why do supermarkets make the sick people walk all the way to the back of the store to get their prescriptions, but they put cigarettes right at the front counter? Makes no sense to me, but whatever. Our workforce, just going to mention it, most of you know, is the most fragile and therefore the most valuable thing that we have. And it is limiting to some extent our ability to do some of the innovative things that we're going to talk about here that people are willing to pay us to do because we've proven that value. But just keep in mind that as we talk about all of these things that we and other agencies have been able to do during the pandemic and are now expanding as a result of the public health emergency, we have got to figure out how to resolve this staffing crisis that we're having. And we're going to talk about one or two options of system redesign that may help that. But this is not necessarily a pandemic issue, but the pandemic exacerbated an issue that many of us knew was already coming. And the people in this conference knew it was coming because you could read the tea leaves. National publications have been pretty prolific on the challenges that EMS is having. It started as a rural issue primarily, but now it's become a urban issue. And now you've got fire chiefs, EMS chiefs, city managers, other people telling folks, hey, we've got a staffing issue, we've got a resource issue, we've got a call volume issue. And we need to relook at the public expectation of what we've been able to deliver for the last 40 years. And maybe things like, and what we've messaged to our community, and I've done it a lot through the media over the last 3 to 5 months or so, is listen, if you call 911 with a toe infection, we will guarantee you same day service, but we are not going to guarantee you a 17-minute response time for that priority 3 call. If you've flipped your car and rolled and ejected yourself and your arm has been amputated, we're going to be there in 9 minutes. But we're going to triage these calls a lot more diligently than we have in the past. And we're not going to commit to having a low acuity 911 call responded to in 17 minutes anymore. It's just not going to happen. You've seen the news articles from other parts of the country where they're now changing the priority 3, the low acuity 911 response, to a 60-minute goal because there's not a time sensitivity. And that's just the reality. And again, we're going to talk about some of this, but just begin. If you're having issues, it's always best to go out front with that issue and begin briefing your community that you're going to do things differently. And no one's going to die, but we might not be getting an ambulance to your house in the same time frame that you normally would because of the workforce issue, because of the call volume issues. Call volume is pretty high right now. Rob Lawrence and a number of folks, myself, are creating a article log that we're going to be making available every Friday to folks here pretty quick, so that if you need to make, and I didn't put it on this one, but there's hot links in this worksheet to each of these articles, so that you can filter them by topic, you can filter them by state, you can filter them by whatever, and go to the hot link and actually go to the source article here. And one of the things that's happened in this value proposition during the public health emergency is the major national associations have been collaborating very, very well. We started it about 1.5 years ago, and we meet every other Friday. The American Ambulance Association, National Association of EMTs, the International Association of Fire Chiefs, and the International Association of Firefighters, and our government affairs staff, so the volunteer leadership and the lobbyists for those associations meet every other Friday for an hour, and we coordinate efforts. And we do all sorts of things just to make sure that our message is being unified and deciding who's going to take the lead on certain issues. The EMS funding issue, I'm sorry, the EMS workforce issue is universal, but the AAA and NAEMT have, with the grace of everybody else, the blessing, I should say, of everybody else, is taking a little bit of the lead here to try and get some federal legislation going to help us address the workforce issue. But I can tell you the IFC and the IFF are lockstep with this, and we're all pushing in the same direction. All right, another quick, difficult question. Why do people order double cheeseburgers and a large fry and a Diet Coke? If you're going to go big, just go big the whole way, order a regular Coke, whatever. But there you go. Okay, so what are the things that have the pandemic has helped? So system redesign. One of the things that's happened because of the call volume, staffing shortage, pandemic influence, et cetera, and the mass resignations that we're seeing in many industries is the opportunity to investigate, test, do things that 2 years ago would have really been considered heresy. So I'll give you the example, and this is the one from our system here in Fort Worth. For 35 years, 36 years, MedStar has been an all ALS ambulance deployment, paramedic and an EMT on every ambulance. And the reality is that's not sustainable. It's expensive. It's hard to get paramedics. It's hard to keep them in a high performance system where they're doing 12-hour shifts and street corner deployment and all that sort of stuff. So we went to our city managers, we went to our first responder groups and said, you know, and the medical director's office kind of led a lot of this, said, we need to really look at doing a tiered response model where we've got BLS ambulances and ALS ambulances in the system, because the office of the medical director did this analysis and took all 360 or however many there are emergency medical dispatch response determinants and looked at the patient care reports for about 100,000 responses in 2019, because 2020 got jacked up with Card 36 and other things, and filtered this data based on the propensity for any ALS care being administered, whether or not the patient was actually transported to the hospital. Did the patient get transported, lights and siren? Was there critical ALS interventions done, you know, advanced airway intubation, et cetera? And did the patient have unstable vital signs? And they set, and we set together, a parameter of a 3% tolerance. So if the EMD codes yielded a patient treatment that fell less than 3% of the time in this category, we all agreed that this determinant, those determinants, could be safely handled by a BLS crew. And we started deploying BLS units. Today, our average deployment peak deployment is about 54 ambulances. And about 6 to 10 of those today are BLS units. This report that you see here from 2019 data shows that about 19,000 of our 110,000 responses in 2019 would be eligible for a BLS response. So we want to get up to about 20% of our deployment, ambulance deployment, at the BLS level. So we set several metrics for this process, and one of the metrics was first responder satisfaction with getting a BLS ambulance instead of an ALS ambulance. And there are a whole bunch of other metrics, but this was just one. And one of the things that we have found is that this model, the first responders liked a BLS ambulance coming on their scene more than they liked an ALS ambulance. And many of you who interface regularly with co-responders on the scene of a call can probably understand why. Because what we heard from the first responders is that when the BLS units arrive on the scene of our call, they're a lot nicer to us than the paramedic units when they arrive, and they don't belittle us, and they don't, because we're all certified and credentialed at the same level, and we just work together, and it's not a big deal. So a number of parameters. If anybody wants in the conference wants the full pilot and all the data analytics that we've done and the outcomes from this, because you want to try and do it in your community, just send me an email. Kim's got my email address, or you can just ask him, and I'll send all this information out, because we think this is a really good way to begin to do leveraging that value by doing system redesign. But again, if we had brought this up 2 years ago, we would have been laughed out of the room, because, hey, every patient deserves a paramedic. And that's really not true, because they don't really need it. and we can staff a lot more units because we can staff them with BLS. And just to end this discussion, we'll move on to some of the others, is our last two new hire academies, even during the pandemic, were the largest number of new hires we have ever put through a new hire academy. Our August new hire academy had 37 people in it, and 30 of them were EMTs. Because in the past, we only hired enough EMTs that we had paramedics. So if we hire 7 paramedics, we would hire 7 EMTs, and we had a class of 14 people. But when we're able to put on BLS units, we can pick some really, really, really good EMTs who have a heart for the system, a heart for the service, and they've been doing an amazing job. The second phase of this may be that in doing the analysis of the BLS determinants that get a BLS crew, a lot of these calls don't get a lot of transports. So we're considering now, for these EMD codes that have a low transport ratio, do we even send an ambulance at all? And if it's a car crash and the first responder, fire department, or police department's going to go, fine, you guys go. We're not going. If you need us, let us know. Or sending a QRV only on that. We've got a couple of QRVs in the system. So we get one of these, a 4 Delta 5, which is an assault, 20% transport ratio. Just send a single paramedic in a QRV. Assess the patient, determine, you maybe do telehealth, determine if they need to go to the hospital. If they're not going to go to the hospital, just AMA them right there. And if you do need transport, call for it. Not a big deal. These are low acuity cases. All right, now there's some fun questions. Why do banks leave vault doors open but chain the pens to the counter? Kind of interesting. Who knows? So value. CMS recognized one of our values in that we could transport to alternate destinations. Now, we've talked a lot about the whole ET3 model and things going along with that, but as part of the mitigation of the public health emergency, early on in April of 20, Medicare said, hey, you want to go to alternate destinations, we're going to let you, and it's going to be a covered destination, just as if you had gone to the emergency department. And when they listed out the alternate destinations, it was basically everywhere. So anywhere you take a patient today, so literally today, if you go to a 911 call, transport a patient to a massage parlor, that's a covered destination. If it's in your protocol to transport a patient to a massage parlor. So CMS recognized that there's some value in preserving healthcare system capacity. There's some value in doing things differently. This sounds a lot like the ET3 model. The only difference is that you don't have to go through the hoops that everybody's had to go through to get this. The problem is there are not a lot of alternate destinations, especially now. We talked about that earlier today, but excuse me, it's still out there. So if you want to do it, go right ahead. No revenue impact because it's going to be handled just the same. Treatment in place. So in March of 2020, our medical director issued a medical directive that basically said, hey, if you guys respond to a patient that has coronavirus-related symptoms and they are hemodynamically stable, you will not transport them to the hospital, even if the patient wants to go. So the patient says, hey, I want to go to the ER. Well, we're not going to take you. I really want to go. No, we're not really going to take you. I insist that I go. You can insist all you want. We're not taking you. I need to talk to your medical director. Fine. And the medical director during the course of this program, which is still in place today, has gotten maybe a handful of calls from the crew say, hey, this patient's really pissed about the fact that we're not going to take him to the hospital. So the medical director tells the patient, we're not going to take you to the hospital. You can call Lyft, you can call Uber, you can walk, you can get a ride, but we're not taking you. This is reimbursable today. We'll talk more about that in a second, but it's also value add because the hospitals didn't want a lot of low acuity patients. And the reason why many systems haven't done this in the past was because there's no money in it. But now there is. We'll talk about that in a second. So we've used this protocol a lot. And it's spiked and ebbed and flowed throughout the course of the pandemic. But August, September, we were averaging 9, 10, 11 patients a day that we were telling them we're not taking them, not AMA'd, because they're taking our recommendation. We're just telling them we're not taking you to the hospital. They didn't have to consent to it. They didn't have to do anything. It's just documented as a COVID treatment in place, non-transport. And the patient doesn't have to consent to us leaving them. We're just going to leave them. We do leave them with information. So we have printed materials that we leave with the patient that we can document what their vital signs were so that if they do follow-up like we recommend and they go see their doctor and they go to other places, we actually leave them this information about how to get tested, where to get vaccinated if they want to, how to isolate in place. We do not do testing in the home on that 911 call, but again, we give them information where they can go get that resource if they want. Now, we knew when we started this program that we were going to have a treasure trove of data, because these are patients that wanted to go. We told them not taking them. So we thankfully have some EMS fellows that work in the office of the medical director, and they did a little project. And they actually called 93 patients that we scene treated and left on the scene, even though the patient wanted to go to the hospital. And the fellows asked them some questions. First question is, how are you feeling now? And you know what? All the patients got better. Nobody died. And yes, we did check ME records and we checked ER records, and nobody died. So of the 93 patients that they were able to reach, nobody died, and they all felt better. Did you follow the recommendations that we left you? And you know what? 98%, 99% of the patients said, yep, followed the recommendations. One of the things that they then asked was, did you seek medical care within 72 hours? Which, by the way, was one of the recommendations. And as you can see, 89% of them did not seek follow-up care. So technically they didn't follow recommendations. Now, of those that did seek alternate care, 4 of them went to the emergency department, and 5 of them went to their PCP or an urgent care center. So very low follow-up care there. Now, the interesting thing is, did you get tested for COVID-19? And about half got tested, and of those, half tested positive. So the crews did a pretty good job of being able to identify people who probably just simply had coronavirus, didn't need to go to the ER. So that was pretty good. But here was the money slide, or the money question. On a scale of 1 to 5, with 5 being most satisfied, how satisfied were you with your MedStar encounter? And look at this, 99% of the patients rated it a 5 out of 5. And these were patients who wanted to go and we didn't take them. So we shared this data with our payers, with Medicare, with the hospitals, and said, listen, we just saved you guys a boatload of money. Most of these patients had insurance. A lot of them had Medicare, some were Medicaid, but some had commercial insurance. Look at how much money we saved you. And oh, by the way, nobody died. And oh, by the way, they loved it. So you need to pay us different. And we included some of the comments. So if you're doing this in your community and you have a community-based protocol that allows you to not transport patients to the hospital, please, please, please mine data, do a survey, because the more data like this that we have that we can give to the America's Health Insurance Plans and give to Medicare and give to your state Medicaid office, you can prove the value of doing these types of programs. Now, this program was enabled because of the public health emergency. I don't think our medical director would have been very comfortable doing this just out of the blue. And most medical directors wouldn't, most EMS chiefs wouldn't, but we needed to, because it was a new standard of care, crisis standard of care. So use this data to make the case, the value case. Now, we did use this data when we were having conversations with members of Congress and conversations with Medicare that they should just pay for treatment in place. And Medicare told us, we can't pay you for treatment in place because we don't have statutory authority. The statute from 1965 says that ambulance transportation is the benefit, not ambulance response and treatment. So we can't do it. And we said, well, bunk on that. A, you pay for a field terminated cardiac arrest, and we don't transport those patients, and you pay for it. So we know that you can do it if you really want to. But since you're saying that you need statutory authority, fine, we'll get you statutory authority. So NAEMT, AAA, IFC, IAFF, we all went to our lobbyists, all went to the congressional folks and said, hey, we need a law that allows Medicare to issue a waiver to do treatment in place. And easily it passed. We got it in, got the language, got it passed. And then literally Medicare issued the waiver that they actually came to us to help with to some extent, didn't take all of our recommendations, but basically said, if you've got a community protocol that says you don't transport everybody to the hospital, if you use that protocol, we'll pay for it. Great, super. This waiver, by the way, so remember there's a waiver for alternate destinations already. There's a waiver now for treatment in place, and you can bill for that. We're billing for it. And you can bill for it if you have that protocol that says you don't take everybody to the hospital, not just regular AMAs, but it has to be a protocol that your medical director signed that said that you don't take these people to the hospital. This waiver and the data being collected from this waiver, we're using to convince Congress and CMS, although CMS is pretty much already on board, that the waiver should just stay permanent. Because if that's the new payment model, that's the new payment model. Patients are happier, saves a ton of money. our out of service time on a transport isn't as long, especially now when we use this in a meeting with some congressional staffers 3 weeks ago with the hospital delays, the drop times, ambulances being out of service for 2, 3, 4 hours, trying to get patients discharged in the emergency department. If we just treat them on scene, we don't have those issues. And this is a workforce mitigation strategy, workforce shortage mitigation strategy. Let us treat people and refer them, keep ambulances in service. And it's ringing true. And a lot of people are very happy with this proposal. I think Tim and others were part of EMS on the Hill Day last year that we did virtually. And this was one of our message points. And there was not a lot of pushback at all. So we think this will probably become permanent. Now, you should do the same thing in your state. And I don't know if Colorado has done this, but a number of states have looked at it, and we did it in Texas. So when during the pandemic and all those things that we just talked about, saving money, increasing patient satisfaction, returning units back to service more quickly. And we were able to convince the legislature and a number of other supporters of the legislature that this makes sense. The legislature put the bill in, it passed through the entire process without really any issues at all. So now Medicaid is required to do the same thing. Excuse me. So Medicaid is going to pay for treatment in place and transport to an alternate destination, because the legislature has said you will do it. And they've got a year, the clock's already running. They've got a year to get the rules in place. They've already reached out. We're working with them to help write the rules. The Texas EMS Alliance folks are helping write the rules for this project, and it will avoid a whole ton of money. And a lot of folks were supportive of it. Leveraging it even further and demonstrating that value, again, find out who your large payers are and take this data or take the concept to the large payers. We have and have gotten a lot of very positive outcomes. This is an example. These are actual agreements where we have commercial payers who, and this is a managed Medicare payer, who put right into the network agreement, yep, you know what, we're transport to alternate destinations. We're going to pay it at the 100% of the Medicare payment rate, and treatment in place, we're going to pay it 100% of the Medicare payment rate. So it's not just ET3. If you're not an ET3 participant, it doesn't matter. You can do this. We talked about that this morning, but here's the example of a commercial managed Medicare plan that did this. We have 3 of these agreements. So it makes a ton of sense.
Hey,
I mentioned it.
Hey, Matt, just a
Yo.
moment. Go ahead, Tim.
Just a quick question regarding your Texas Medicaid legislation. Does it include the requirement to meet the medical necessity for a transport before it could be paid? Or were you successful in leaving that out of your bill in Texas?
Yeah, it's not addressed in the legislation, but in the rules, we're gonna, and HHSC, the Medicaid office, agrees that the medical necessity, because this is what CMS did, there is no medical necessity bar for treatment in place, because we just go. We're not going to triage a 911 call to say, well, we are, but we're not going to tell them that we're not going to send an ambulance, because we don't know what's wrong with the patient until we get eyes and hands on the patient. Once we're there and we can do an assessment, yeah, this is a bullshit call. This is a low acuity call. The patient doesn't need to go to the emergency room. So there is no medical necessity for the transport. Now, I'm sorry, for the non-transport. That is not true both under the ET3 model and in what will likely be the rule for the Medicaid implementation. If the patient needs to go to an urgent care or needs to go somewhere by ambulance, they will need to meet medical necessity for the ambulance transport. So there has to be an extremity fracture or require medical monitoring and all that sort of stuff. But that's fine. You know why? Because 80% of the ET3 model implementations or ET3 model interventions are treatment in place. These people don't need to go anywhere. So we're not concerned about the medical necessity for the transport to alternate destinations, because it's no different than a transport to the emergency department. 20% of our Medicare claims are rejected for lack of medical necessity in a 911 call anyway. So just let us leave from there and pay us for that. So that's our approach.
Thank you, Matt.
So the ET3 model for treatment in place versus TILT are different, because TILT everybody can use, and that's the one that has to meet the medical necessity for a transport, but they weren't transported, they were treated instead on scene.
Correct. So it's and it's not in the waiver, but we're calling it treatment in lieu of transport. It's the but for provision. But for a public health emergency, you would have transported this person to the hospital. So there is some medical necessity there, but I'll share with you that we've billed, I don't know, 150, 200 of these recently, and none of them have been rejected for lack of medical necessity, because again, they understand that we don't know what's wrong with the patient until we get there. And that they're just grateful that we didn't schlep them to the ER. It's been pretty fine. So,
Thank you.
this was one, I may have referenced it this morning, but here's the actual deal. I don't know if I had this in the morning presentation, but this is a commercial payer that is going to pay us the same for non-transport as they do for an emergency transport. What I may not have explained more fully this morning was that up until, and this agreement will go into effect on January 1st, up until January 1st, the average reimbursement that we get from this insurer for both their payment and the balance bill that we send to the patient today is about $1,000. So they're going to pay more than we got combined from their reimbursement and the balance bill that we sent to the patient. And in the network agreement that we're in the process of reviewing and finalizing, it clearly says that we don't balance bill the patient, and we're not going to balance bill the patient because you're already paying us more than we would have collected had we balanced bill the patient. So we're fine. But this is made possible because we were able to demonstrate to this commercial payer and a couple of our others that not transporting patients is safe, it's effective, it has high member satisfaction, and it saves you buku dollars. So again, leverage those innovative things that you're doing out of necessity to show that you can be more valuable to the payer than just schlepping people to the hospital. So,
Matt, we've got another question.
okay.
Matt, are you only getting those payment rates when you are contracted with the payer? Or are you getting them in non-contracted instances as well? Like,
Great
Yeah.
question. Here's the reality. Most payers will not do an alternate payment model with you unless you are in network. And it has less to do with the payment rate and balance billing and all that kind of stuff than it does the indemnification clause, the shared data clause. They want you in network for those reasons in order to pay you for the alternative types of services. And we're okay with that. The reason that we've never gone in network before, probably like many of you, is because getting a lower rate and not getting a higher call volume because they're not influencing 911 callers doesn't work. So the fact that they're paying the full rate, in some cases higher than what they have reimbursed in the past, and they want us to share the liability if somebody dies because they're doing something different. They want us to share data across the agencies. That's all fine. So we've gone in network. And again, for 35 years, for 33 years, we never signed a network agreement. We signed our first network agreement with Blue Cross Blue Shield in 2016 because they were going to pay us a capitated fee instead of fee for service. And now we've done 5 network agreements, and every one of them, we're getting at least what we were getting at being out of network, and in 3 cases, more than we were getting when we were billing out of network.
so your key is though, you're telling them that you're not gonna pay us crap for a 911 transport, you're gonna pay us reasonably. And you're able to make that happen. Do you think
Exactly.
you're only getting that because you're such a monster in terms of transport volume? Or do you think that's possible for an agency that does 4,000 calls a year?
It's very scalable because here's the scenario with this particular payer. When we said, hey, we want to get paid for non-transport, they said, great, we're willing to do that. Their first offer was $1,100, $1,200 for a transport and $309 for a non-transport. And we said, okay, you can offer that. We're not going to do it. You'll never see that claim come through because we're just going to force everybody to go to the ER. Whether we're doing 20,000 transports for them or 3,000 transports, it doesn't matter. When we told them it has to be the same as if we transported, they said, well, we got to do some more actuarial analysis. We'll get back to you. And it took 3 days. And they emailed back and they said, okay, we're good. Yeah, we're just going to match the rate, because they did the math. And they said, for every patient that they transport, we pay them $1,100, but we pay the ER 4,000 or 5,000. So whether you save 10 of those or 1,000 of those, it's a savings.
Agreed. Thank you.
You're welcome. Why do we leave cars worth thousands of dollars in the driveway and put useless junk in our garage? Just people do that. And by the way, just so you guys know, this is Kim's driveway. I took a picture of this for the presentation and just,
And that's very accurate, actually. Very good. And I mean the one on the right, not the left.
all right. If you're not doing COVID vaccines, shame on you. It's a huge community benefit. It's great revenue. I didn't put it in here. I think I may have had it in a different presentation, but we're doing one today for the public, and we've had 40 so far. We're doing it until 6 o'clock. If you take the minute that it takes to file a what they call a mass immunizer authorization, which is what we've got, and it's real easy. You just do it with your local MAC, and it takes about 45 minutes, and they email you the form, and now you can do roster billing. And quite frankly, it's a great relationship builder with your payers. Our largest managed Medicaid payer sends patients to get vaccinated, or we're doing a route for them, a different managed Medicaid payer for pediatrics. And we're going to be doing pediatric in-home vaccines, and they're going to pay us $75 a vaccine. So we're good. Here's the reimbursement. It's really good. No deductible, no co-payments. You just submit the roster and they total it up, send you a check. And it's a really good way to do that. Monoclonal antibody infusions, you can get paid for this using the same authorization that you get from the Medicare administrative contractor as a mass immunizer. You can bill for monoclonal antibody infusions. Again, great community benefit, great way for you to build your value in the community, because people who get COVID and they don't want to get admitted, they can come. The reimbursement for this is pretty good. It's $450 for essentially a 90-minute infusion. And if you can do 3, 4, or 5 of these a day with a light duty GIMP paramedic, a light duty paramedic who can't work on an ambulance, then it's a great way to make some additional revenue. We're doing these 5 days a week between 10 and 6. So it works pretty well. And again, great value. This is another one of our large payers. They're sending patients over to get infused because they're interested in keeping their patients out of their members out of the emergency room. So they're referring patients over to us for an infusion. Why do they sterilize the needles used for lethal injections? Interesting question. Last couple things here is MedStar on Demand. So we put into place, we knew a lot of people weren't calling 911 and they weren't going to the ER because they were afraid to. So we have a subscription program, and many people have subscription programs. We customized our subscription program to what we call our Star Saver Plus or MedStar on Demand. And for $350 a year for your entire household, you get all of the benefits that you would normally get for the $69 membership, where we waive your deductible, coinsurance, et cetera. But if you call 911, we're going to send a community paramedic to co-respond with the ambulance. We're going to navigate you, and we're going to give you the opportunity twice a year to call our non-emergency number. And, I don't feel well. Can somebody come out and check me out? 2 o'clock in the morning, 2 o'clock in the afternoon, whatever. We're going to do that. And this has been a very, very successful program. And it's a great revenue stream and very little utilization. But again, just ready responders, Aspire, all of these pop-up venture capital funded community paramedic programs are offering this in your community, or will be shortly. You might as well get out ahead of it and just offer it. And there's no reason not to, because low utilization, great value, and you can actually generate some revenue from it. So here's some of the things, takeaways before Scott comes in. He's already texting me, probably saying, what the hell are you taking so long for? Oh no, you made me laugh. I know, it's my face. It's funny. I'm going for the Harry Potter look here. So just help us prove that treatment in place is safe, share your outcomes, do some 5-year financial projections for some of these programs, and you'll be astonished at, if you're doing this right, you can really sell it and sell it well. And make sure that you're encouraging your associations. If you're a member of any EMT or the IFC or the AAA or the Colorado State Ambulance Association and EMS Association, please encourage them to collaborate with other associations. There was a article that I think I sent out yesterday about the American Hospital, maybe it was this morning, the American Hospital Association picking up the slack to really push against this provision in the next Build Back Better plan that eliminates disproportionate share and uncompensated care payments to states that did not take Medicaid expansion. So I sent that to any EMT and our lobbyists and some of our lobbyists that we know and said, hey, listen, why don't we call the AHA and partner with them and tell them, hey, us too, because we get these reimbursements. So we're happy to help in whatever way that we can. Just find those alliances, because the enemy of my enemy is my friend. And you can really have some good opportunities to build up those requirements. All right. Thank you guys for everything that you do. And the point of this part is we have never, as a profession, we have never had as much recognition and as much respect from our local communities and from our states and as we have today. Leverage it, take advantage of it. As John Washko always tells us, never let a good crisis go to waste. If you want something, ask for it. We just in the last legislative session, we wanted a workforce development grant program or funding at the Texas legislature. And we asked for $27.1 million for EMS workforce development, gave them all the reasons why, told them the 4 programs that we wanted to do, five programs that we wanted to do. And even in Texas, which is very fiscally conservative, that ask of 27.1 million made it through the entire legislature and to the governor's desk and signed without even having to go to hearing. Because they recognize the value and the crap that EMS has been under over the last 2 years. Use that and leverage it. It does work. All right, Kim, any other questions from the team before Scott takes over?
One final question for you, just to remind you to please send the CMS waiver regarding star clause and kickback.
Thank you. I'm writing that down. And I will do that as soon as I log out and Scott logs in.
Okay, and I will forward it on to the appropriate parties here.
Thank you.
I see no questions online, no questions in the room. So Matt, thank you again for both your presentations today. We will see you in the future.
Thank you all. And thanks, Scott.